just for my information, majority of the people in this group are from physical therapy,
Physical medicine, yeah.
physical medicine. Okay.
Hmm. And Connor and Sherry and I, along with three other individuals,
Uh,
are on the board for a nonprofit called Syracuse Spinal Association.
oh, okay. Okay.
And Lindsay's right there.
Oh,
She's one of them. So you guys definitely chime in if you want to help me describe it. But we have this group that meets once a month, the second Tuesday of every month. We try to have different people come on and speak. If we don't have a speaker, we just still come on and discuss whatever topics members want to talk about or have questions about, concerns. People can share their experiences and their stories and their advice, ask questions. And we also have a grant that it's $1,000 for anything medically necessary that maybe that insurance won't pay for that people can apply for.
excellent.
We try to do some social outings and get-togethers also.
The
For
table, have our table, like
yeah, different events to do, fundraise. So we like do tabling at events. We were in the Boxing Hall of Fame parade. Sherry organized.
that was fun.
That was a lot of fun in Canastota just to get the word out of what we have to offer. 'Cause there's really not anything in the central New York area like this. I think the closest one to us is Rochester that has a group that's similar. So we tend to get people from up north too.
Oh,
So started it about, I think it was like 8 years ago now. It's been a while.
It's good. I found them by chance. I found Syracuse Spinal Association April of 2024 from the Rochester Spinal Association. So I was it was so nice to just hear other people's stories. And I mean, everyone was so welcoming, and not many people understand what you go through with a disability. And here with the Syracuse Spinal Association, it's just a very loving, caring group from what I have experienced. And I know it's changed my life, getting to know them and just feeling part of a community where normally, you'd have to go out of your house. And here we are, due to different geographic locations and disabilities, we could just do it right on Zoom by the technology that we have in today's world. So it's really a great association. Proud to be part of it.
mhm.
If you'd like, Dr. Chohan, you could get started if you wanted to tell
Okay.
us a little bit about your background and
Okay. Well, I'm a vet by my first profession. I practiced large animal veterinary medicine for 16 years. And then I went to University of Minnesota, did my PhD in animal OBGYN, and it's a degree called Theory of Gynecology, which is a combination of pathology, OBGYN, reproductive physiology. It's a combination of everything. Then I did my fellowship in clinical andrology and embryology from University of Utah School of Medicine, and two more fellowships. I worked on nuclear transfer, stem cell biology, cloning, all those areas. So originally, or basically, I'm a reproductive biologist, physiologist person. And in 2004, I joined Upstate as associate professor and andrology lab director. And currently now I'm a professor in OBGYN and pathology. I cover this area, uh, whole area, and I also has clinical professor appointment at University of Rochester. So in this area, actually in fertility area, what happens is that majority of the my job is fertility diagnostics. This lab, this Upstate made me a male fertility reproductive pathologist. So it's my main focus is on diagnosis of male fertility, different issues with like semen analysis, sperm DNA fragmentation, and sperm antibody production. We diagnose all that. And on top of that, we started running a program on male fertility preservation at Upstate for cancer patients. And for your group, we can do that too. So this whole region from Watertown to Scranton, middle of Buffalo to middle of Albany and Syracuse. I cover all that area up to Guthrie Hospital. There are 5 or 6 specialized andrology labs left in this country, and Upstate is one of them, where we only specialize in sperm. And whereas in other labs, people who are doing hematology work, they are also doing sperm work, which is not going to give you consistent and specialized results. So we are kind of a reference lab at Upstate. We run this program here and at Rochester, and our male fertility preservation program is at Upstate. So that's my whole background in this area. I just came last night from Virginia, and I did not know a lot about this group, and I did not make any slide presentation for this group. But I do have my coming lectures next month, my grand rounds with University of Rochester, which are basically understanding a semen analysis, understanding fertility diagnostics, what other tests tell us, preparation of techniques for assisted reproduction, and all those kind of lectures. And if your group is more interested in that, I can share the link, or I can come back and talk about lectures individually on that.
I forgot about the Syracuse Spinal Association meeting. So I'm doing that.
If you guys, I would love to come with my funny cartoon slides there.
What did you say?
Yeah, I attend that I present at others, but this will be pleasure to come and present a slide presentation there. Please keep me in the loop. This will be an honor to come. So today, the message I got that it's going to be an open discussion. You can ask anything about this area. I'm not a MD specialist who is going to treat patients. I can tell you what I can do for these patients, how we can aspirate sperm, how we can make fathers, and how they can start a family. That's my area, and there I will focus. So once we get a spinal cord injury, there are 3 main factors which affect a patient. First, mostly the male, it affects males more than females. Male is the more victim on that, and 3 things happen. The first is erectile dysfunction. Majority of these patients, they face erectile dysfunction, which can be treated by a urologist. And the other one major factor, one of the other factor which is affected is called ejaculatory dysfunction. The third part which happens is the abnormal sperm quality. We can go one by one, but I will less focus on erectile dysfunction because there are more potent medicines out there. There are prosthetics and all those kind of stuff available that a urologist can use to help the patient to have that. But to have a family, this is not necessity that a patient should have erection and have that activity to make a baby. For this thing, we need to have only two things. On my way back from Virginia, I just listened to 1 or 2 YouTube pictures to see what is out there. And there was some good information and there was some wrong information. And I will explain that information in my discussion here. Well, going towards the ejaculatory dysfunction, majority of these patients cannot ejaculate. What happens in these patients is that instead of semen, if they get that senses to ejaculate, instead that semen comes out, it goes back to the urinary bladder. Most of these patients face a condition called retrograde ejaculation. That is one major thing that we see in these patients. So once we try to get an ejaculation, there are different ways to do it. The first thing is that there are 2 approved techniques or 2 procedures available out there. These are called penile vibratory technique. There are 2 vibrators available and they are approved by FDA. the one part goes on top of the penis, one goes on the below of the shaft, and you give some pulses to that, and you collect the sample in a cup. So this procedure can be done at home, and couple can use that technique at home and use that semen for vaginal insemination. But the wrong information in those talks were that the patients can use this semen and can directly inject that into the uterus, which is going to put the female into emergency room. What happens is that semen is a combination of two things, seminal plasma and sperm. Seminal plasma comes from prostate gland and seminal vesicles. Prostate gland produces proteolytic enzymes which liquefy the semen. What happens in bigger species where they produce a big ejaculate and the semen needs to be kept in the vagina for a longer period of time, this prostatic fluid helps to keep it there. And in humans, the first 2-3 drops are totally rich in sperm, and in a ovulating female, they immediately enter the cervical mucus and go there. But specifically, if a patient collects a sample by penile vibration at home, they can use that, I don't know how you say that procedure, that you can use that cookie based or whatever that is. You can put that into the vagina and leave it there and maybe you can make a posture. I have few cartoons on that too, and let the sperm do their work on that. The other system which works is called intrauterine insemination. That insemination should only be performed after washing the sperm and in doctor's office. A neat semen sample should never be placed into the uterus because it is having leukocytes, cytokines, viruses, bacteria, and it is one major thing that it contains is called prostaglandins. Now, prostaglandins come from the seminal vesicles, and they contract the smooth muscle. So if by mistake a female injects that into the uterus, trust me, many doctors have done that too. A female will be in ER with cramps, and then she will be put on antibiotics to overcome the infection. Naturally, vagina is a system that it cleans up the sperm, and only good sperm, there is a siphoning system between the opening of the cervix and cervical fluid that only allows to let the good sperm go on there. Now, the problem with these patients is if you collect semen from them, semen is of very poor quality. The semen they may inject the semen because they may never know the quality of sperm, color of the sperm, and anything. So there is a probability that they may never conceive if a couple wants to use their technique. The other old method which is available out there is, which I used at University of Minnesota many times, and one bull stepped on that and broke that too, is called electromagnetic electroejaculator. I used to use that to collect bulls in Minnesota, and I know how painful that is. Even the bigger bulls, they were like in bad shape to hold that big rectal probe in there, huge. And this procedure was developed in 1930s to collect semen from bulls, and then it was modified and used in humans many places. And there is an ICD code for that too, if you want to collect a semen sample in these patients from them. But it's painful procedure, and it is done by a urologist. In my 21 years of service at Upstate, I know that we don't have that protocol, and we don't have that procedure at Upstate, or a machine at Upstate. The other procedures are called surgical procedures. Let me talk about this procedure too. If a few patients may contribute a semen sample, but the sample of that semen will be mostly yellowish, because these patients are not having control on defecation and urination, and mostly it's a yellowish to brownish color, whereas normal semen sample is white gray color. So in these patients, This is the normal color. The longer the abstinence period, the longer the quality of sperm goes down. It takes around 80 days for sperm to be produced. So if a patient is having every 80 days, sperm, a new fresh lot of sperm is ejaculated. So if a patient is having back injuries and all that, and he is not ejaculating for a longer period of time, he is just sitting there. And while sitting there, his all these testicles, his accessory glands, they are not functioning properly. The first impact of that is that he's always having like sitting, and that it's increasing the testicular temperature. Similar condition I have seen in computer, people who sit a lot in computer. One of my resident, she did a study on profession and semen parameters, and we saw that the people who stay all day on computers holding their testes between two legs, and the truck drivers, they are having the worst semen parameters. Now if a patient comes, we ask the patient a profession. If a patient says I'm a truck driver, we know immediately that he may have some like poor motility and all that kind of parameters. The other issue is which affect quality is the presence of neutrophils in the ejaculates. These neutrophils produce reactive oxygen species, and sperm are lipid bilayer, and they damage the membranes. And once they damage the membranes, there is no protective mechanism, and they go and damage the sperm DNA. And if DNA is damaged, I have a 40-minute lecture on that, actually just on sperm DNA damage. And we offer that test here at Upstate, and I'm one of the first one who was awarded. That was my postdoc work on that. So if a patient is having, okay, we got semen sample, but if it is having high DNA damage, and if a patient is having more than 30% DNA damage, the chances for them in natural life are very low to conceive. And in these patients, while sitting there, inflammatory process and all that makes those sperm vulnerable to DNA fragmentation. On top of that, sperm regularly undergoes apoptosis. They are continuously coming up, continuously dying down. So in a normal life, when we evaluate a patient, we tell them to keep sexual abstinence period between 2 to 5 days. But in these patients, the sexual abstinence period is longer. We don't know how either they are able to ejaculate or not. So at the same moment, people say they are having bad semen parameters, but they may be accumulating bad sperm into the ejaculate. They never get rid of them. That might be a factor too. So the other collection methods are called surgical methods to collect semen samples. Where we directly collect semen, we can collect the semen sample from the epididymis. Epididymis is a storage and a maturation site for sperm. If we open epididymis, the consistency will be like a toothpaste. The epididymis, the sperm move from the head to the tail. Once they get from the head to the tail, they become like strong with disulfide bonding, and they get the ability to move. So a urologist can get the sample from the epididymis. The urologist can take a testicular biopsy and take the sperm and send the biopsy to us, and we can process that, and we can isolate sperm from that. Or he can get a fine needle testicular aspiration. These are all procedures successfully used in assisted reproduction now. The first procedures we talked, where we can get semen sample by electroejaculation, vibratory ejaculation, we can use them for artificial insemination. I will prefer after washing the sperm, depending on the quality. We need like 10 million sperm in the ejaculate. If we are successful to even have 1 million, 500,000 washed sperm and can directly inject into the uterus, we will achieve a pregnancy. But for the surgical procedures, they are only meant for intracytoplasmic sperm injection, where they can pick up a sperm and put it into the egg. So that is routinely done, and that is the great possibility for spinal cord injury patients. Now, there is a difference in the quality of the sperm. Ejaculated sperm most of the times have poor quality in these patients, whereas once you get them directly from the testes, they may give you better results for the ICSI outcomes, because they have not been exposed to the inflammatory process, they are not staying in the epididymis, or they are not exposed to any of the external environment. So that is the best way to go for these things. So no, it sometimes these patients, they plan to have a baby. The majority average age for the you know more than me in this field, that their average age of injury is around 42 years, and sometimes it happens in the younger age, and in the military men that's quite often happens. And that age, if someone gets injury, they can plan immediately on that I will suggest, like someone got injury, it's way better that they get the testicular aspiration and get those from frozen. It's like a cancer patient. So you are diagnosed with cancer, immediately you should be given fertility preservation counseling with that. I will suggest that with the spinal cord injury, we should also focus like cancer patients and give them a thought to think about these things, because over period of time, the semen parameters are going to go down and down and down with these. So at Upstate, we have fertility preservation program that we can help spinal cord injury patients. If the spine fellows, spine doctors, or urologists, they plan something to do, we offer our service to them, that if they like want to collect the sample with any means, they provide the sample to us, we can freeze the sample for them for long term. When we say long term, they are frozen. We are still creating calves from the semen which we froze in 1930s and 40s. Yeah. So these are the possibilities available at Upstate. And if you have any question, I will leave it open. Please continue the discussion. I don't have much to add to this at this time, but if I can answer your questions, that will be a pleasure. That I don't know much, but we'll discuss.
I have a couple questions.
Sure.
One is, so it sounds like that's something that maybe, do you think that's something their PCPs should be suggesting to them or bringing up in their?
It should. I personally, being as an andrologist, I would recommend that they should think on this. If they are in a reproductive age, they should think on that. They should think, because over a period of time, the quality of the semen will go down. That is an option, because after the injury, it's a fresh, and their testicular function is good. And over a period of time, in these patients, since they are not moving a lot, they may face obesity and all these. And in obese patients, semen parameters really go down. The average average normal motility there are three basic parameters, which I will say. First one is count. How many sperm per ml? We want to see 15 million sperm per ml. We want to see 1.5 ml average ejaculate volume. We want to see 40% motility on sperm, 32 progressive, and we want to see at least 4% normal sperm. In patients with the spinal cord injuries, the average motility is around 5 to 10% in these patients. And I will, in a reproductive age patients, I will suggest that we should talk to them like we talk to cancer patients. If they understand that and they need to have that, at least they should be given education on that.
Yeah, that's actually what I was thinking about. I actually had a patient only very young, but with cancer and a child. But
Uh-huh.
I think because of the treatments he was going to go through, I'm sure it was a very hard decision for his parents, but they wanted him to have the opportunity to have children someday. So
Yeah. So we freeze many young children here, like who can produce a semen sample. There are two things happen in these kids. Adolescent kids, they produce semen samples. and we freeze them. So the young kids who are not have initiated spermatogenesis, what happens is the testicular architecture is totally different in an adult person and in a like a child. The architecture of testes changes with the onset of puberty. Before that, it's just testicular tissue, unorganized testicular tissue, and there are stem cells. Once we reach puberty, then the whole architecture that I can talk in different lecture, the whole architecture of the testes, seminal vesicles changes, and the spermatogenesis start. So for the young kids who are not in an age that they can produce sperm, I did few things, but now I send them to center of excellence. There are few center of excellence places because you need an IRB approval for that. That is experimental, that one day we may transfer these spermatogonial cells or stem cells back to the testes in cancer patients, or we can produce sperm cells in vitro. The studies have been successful in primates. Pittsburgh is a big center in Dr. Orvig's lab in there. They have successful pregnancies in primates with the injection of these primordial germ cells. So for the other cancer kids and adults, we freeze testicular biopsies. We also freeze main semen samples all the times. We are at Upstate. If you need any information, any counseling, we can. I'm always sitting there to provide that and answer patients or doctors' question there. And I believe that fertility preservation is an option now for many health insurance companies now.
That was my next question, is how much insurance typically does cover that, because it could be for a lot of years.
Sometimes they don't cover, but Dr. Judy Seema is having a grant in Children's Hospital that pays for them. She has some money for the people who cannot afford that.
What about the other procedures that you stated for adults?
Uh-huh.
Are those typically covered by insurance?
The penile vibration thing, I think that you can buy that from even Amazon, or you can buy that. It's FDA approved. It can be used at home. A couple can use it, produce a sample, take it to the lab, and get it washed and get insemination done in doctor's office. Yes, the electroejaculator one, that is having ICD code for sure, that a urologist can provide that. The ICSI, the surgical, majority of these patients, they go for IVF kind of thing. They don't go for IUI and all these things. So all of them are covered by insurance companies. New York State provides $60,000 lifetime coverage for fertility, for related issues, fertility preservation issues for the couples. That's one of the best insurance that it is covered in New York State. And they cover all those epididymal aspiration, fine needle biopsy, TESI, all these kind of procedures are part of the procedure for IVF now. And they are covered.
So that would cover the procedure, the surgical procedure, and
yes, they will cover the
preservation?
surgical procedure. And if they want to freeze the surgical procedure, they want to do it ahead of superovulation cycle in the female. So they will do that, they will freeze it. And at some places, if they know that patient is producing sperm, they do on the day of oocyte retrieval, and they use them for ICSI. Yeah, there are many ways. As long as we can freeze the eggs, as long as we can freeze the sperm, you have a total control on the procedure. And luckily, we have techniques that we can overcome the hurdles on this.
So people with a spinal cord injury typically would do the surgical, and then it would be IVF.
It will be IVF.
Yep.
Mostly, majority of bulk is going that way. Yeah. These I have not seen any electroejaculation or penile vibratory procedure in my 21 years here. All of the patients who are having that, they went through IVF. So these are available. if a urologist is interested to do these procedures, I don't know if they have it or that pay less to them, or sometimes you get the ejaculation, sometimes you end up with nothing. It all depends. It's easy for them to prick the testes and get the sperm out, or go through percutaneous, or go through the epididymis and get the sperm out with the fine needle. That gives them more sperm for IVF.
And you were talking about the lower sperm motility in
Yes.
patients with spinal cord injury. Is that related to like what you were saying about like the sitting position?
Sitting position is one of the factors. The other conditions, like they are having inflammatory process too. That's also part of that. And obesity, sitting all day, depression. And I truly believe that once you also give antidepressant to these patients, if I'm not wrong. I have seen these antidepressant to overcome the depression of spinal cord injury because it's a life-changing event. Majority of the antidepressants, they change the quality of sperm DNA damage, and they make the even normal people, they make them less fertile in that way. There are many medications that I can simply give you an example, like calcium channel blocker. I ask this question to every patient: are you on a blood pressure medication? Yes, calcium channel blocker. I say, tell your PCP to change that medication. I can tell you why. Sperm need a calcium channel open to activate and reach the site of fertilization. If are you giving a calcium channel blocker to a fertile gentleman, that will also block that channel, calcium channel on a sperm. And instead of helping that patient, we might be creating a problem for the patients. And there are medications out there that you can see the ones who are having bad effects on semen and semen parameters. At Upstate, we get all that history on the card, and we evaluate every sample. Like it's not a lab like we do a hematology that give you the readings that this much found, this much found. No, you get a full report as a pathologist from here. We give you the artifact. Sometimes we tell you what to do for the patient. Yeah.
I think this is interesting because this isn't any like information when I was going through this, any information that I was given throughout the ICU stay of weeks at Upstate, and then also at a specialty spinal cord injury rehabilitation clinic too.
Mm-hmm.
So it's good to hear, this, and I'm glad we're getting this information out to especially newly
Please.
injured spinal.
Yeah, I'm always there if I can be of any help. If you come up with any questions, please call Andrology Lab. Yeah, I'm always sitting there. And if some patient needs help, I'm available there. Yeah. And if you will be willing, I will be happy to come to your meeting and present something at your conference. That will be an honor. Yeah. And if you need me to share the links of my future talks on specific issues, I got a request. I had a grand rounds there at University of Rochester. After that, I got calls for 3 lectures, which are scheduled for August on 3 different topics on that. I can share the link, or I can come back and share those topics in this group, and I can talk on every topic for like 1 hour with the slides and everything if you need further information in this area.
Going off of what Connor said, I was wondering if you have given this similar lecture or plan to for like the trauma team at Upstate, or even like the physical medicine and rehab team, because it seems like Connor wasn't aware of this information. So
No,
maybe those teams
nobody
were.
ever contacted me, and I requested our team, which like advertise on the TV. They ran my slide for a few days, and then they stopped it. I don't know why. It's very hard, but if you can spread the word, if you want me to come and talk into your program there, I'm always available. I'm always available for any. If you want me to come to the clinic and talk to the patients in a team, I can come there and talk to them about their fertility issues if they have.
I feel like it seems like a long process, but also a process that could be something so easy to give patients something that they think may have lost after an injury like that.
Yes. After like recovering and after eating well, it's a human nature that you want to reproduce. Majority of the individuals have that kind of inside feeling that I want to have my future generation. And to the cancer patients and to the spine injury patients, I truly believe that we should give them hope, a good hope, and we should inform them that there are treatments out there that they can make babies. I don't know how much, but I just added a little maybe today for you.
Yeah,
No, great
I feel
information.
like, oops, sorry.
And just something like we could, you know, put up when we're redoing our site here soon. Put up some, you know, just general information and you know, link your clinic to which
Please. If you have specific requirement that we should create a brochure for your program, I have a fertility preservation brochure for the cancer hospital. If you need, we can work together. We can make our clinic and your program together on a single brochure for these patients.
I think that would be great. Maybe we could,
Yeah.
Dr. Calasante, with
Yeah,
that.
please talk. We can make that combined brochure.
And
And
I think that's a great idea.
I know that Upstate Clinical Pathology is moving to the Bone Joint Center, but they told me you will have a beautiful office there. But I intentionally decided that I want to stay at Upstate because they put the IV lines to the patients and then they wheel in the young kids for the fertility preservation at Upstate. So if I go there, there is no way that the sample can be sent there. So I sacrificed my beautiful office with a big window, but I decided to stay at Upstate in an office without window, but I want to help the patient. So I will be at Upstate. This is the good thing, that this lab will be, fertility preservation will be at Upstate. Patients don't have to go out.
That's wonderful.
Yeah.
But thanks for making the sacrifice of no window.
No. That's we are. We have to help we are a big human family. We have to help each other if somebody needs that. Yeah. Or you will not believe, when I started this tissue bank, me and Crystal, we never got paid for that. Many, I am not still paid for that. My technician is now full time due to that because it's a lot of patients. But we started with Dr. Judy Seema's grant money, and we just started it because the cancer center, I don't know why they missed that they are making a big cancer center and there is no fertility preservation program. There is still no fertility preservation program for females there. They send them to private labs. If they establish, someone can give me ovarian tissue, I can still process and freeze that. But that's not existing. Since I work with Andrology, with our resources, we develop the male fertility preservation program. And which is more kind of your need with the spine, because it's mostly male fertility is affected. Females can still bear a child and have birth because they ovulate.
Dr. Kazim, are there any concerns to be held for the offsprings that are produced from the like spine preservation procedures?
No. There are no genetic effects on that due to any bag surgery or bag issues. But sometimes I can tell you that there is, since they will increase the DNA fragmentation in the sperm, and once an egg is fertilized by a DNA damaged sperm, mostly those embryos fragment. They don't become marula or blastocyst. They fragment. So majority of the times, they will not implant. But now I tell you something. Good thing is that in IVF program, there is called PGT, pre-implantation genetic diagnosis, PGT. Though it's still like kind of questionable thing. When in early days we used to do pre-implantation genetic diagnosis on a blastocyst, like having maybe 18 to 16 cells. We used to take one blastomere and send it for analysis. But every single blastomere in an egg is different. And these blastomeres, once they divide, few of these cells become the trophectoderm, which is the placenta. And then few of them make the inner cell mass like trophectoderm, mesoderm, endoderm in the center, which makes a baby. Now, this technique, which is like $1 billion industry, many of the specialists, they consider this that this is a big burden on patient, and not every embryo should be biopsied and sent for that. The issue is that inside an egg, there is a selection process. The embryo itself selects the good cells, good blastomeres for inner cell mass, and it sends out the mosaic cells having bad chromosomes or the abnormal chromosomes to make the placenta, which is trophectoderm. And now the whole PGT industry is based on trophectoderm, where you take a piece of trophectoderm and send it for analysis. And there are maybe thousands of embryos sitting in the frozen containers now based on these techniques. And there are two groups in this country. One say PGT is good, other says no. But if I'm the one who has a IVF for my loved one, I will, and having a spinal cord injury, I will certainly go for an embryo IVF, and I will add on PGT for that to overcome any issue related to fragmentation or anything. But technically, if a person is genetically normal and he is not having any issues, the outcome of these all the procedures, no matter you do IUI or you do IVF, you will end up with a normal baby.
Great, thank you.
You're welcome. You're welcome. So let me know anytime in future if you have some specific topics and you want to understand them. And I'm looking forward to come to your meeting. Yeah.
Yeah, we would love to have you back again.
I'm called entertainer in those meetings. My area is fun. I have big talks on environment and fertility, and I want to give a lecture in my life. Your fertility from breakfast to bedtime, where I have studied all these vaginal lubricants and their effects on sperm, and all the cooking oils available in the kitchen that you can use in emergency as a lubricant. I have studied all of them. And even food colors and all of them, I have studied all those food colors too, and their Mountain Dew effect and all. I have studied everything on that. It will be a fun talk. Yeah. One of my master's student, he asked me, is Mountain Dew dangerous for sperm? I said, go and you are studying the food colors. So he studied the food colors, and yes, yellow dye is the most toxic to the sperm, and in 4 hours it damages the DNA. Wow. And I'm not a fan of these food colors. Now I hear they want to ban them. That makes me very happy. I was running at the gym at Upstate, and I was 2008. I was reading that Time magazine about bisphenol plastics. I came to the lab and I gave the MS project to one of my students who is an OBGYN doctor. He went to Einstein based on that project, and on that presentation he got a scholarship. And we studied bisphenol, octaphenol, and phthalates, which are found in your plastics, makeups, and everything. Trust me, bisphenol was the most toxic thing. I don't drink BOP in plastics. I hate that, and all these things made my life and all the environmental. If you want me to come and just talk on environment and fertility, I would love to talk on that too. You decide. And it's an honor for me to be part of this group.
Thank you so much.
You're welcome. You
really, it's a pleasure. Such a pleasure having you here.
This is one of the good paper. I can send the link if you need and want to read on that. It has some pictures, so I will send that on your group if you, and as a PDF file. It's published in 2009. It was published in 2016 in Journal of Andrology. It has everything in there if you want to read as a fellow or as a health worker. It's a very composed paper. I will attach that in an email to your group.
Thank you.
You're welcome.
Very interesting.
Okay, well, if there is no question, then we all can enjoy the evening.
Yes.
Uh,
Thank you, Dr. Chohan.
You're welcome. Thank you so
Yes,
much
thank you
for the
very much.
invitation. I appreciate that. Thank you. Thank you.
Take care.
Thanks.
Bye.
Bye.
Wow, he is very intelligent, a lot of information.
I think Connor has this recorded so we can share it, which will be great with people that weren't able to make it. All right. Does
I wanna
anyone have
know-
any questions about anything? Hey, Michelle.
Hi.
How's it
I want
going?
to know who was part of the clinical trials for all the lubricants. I've done a lot of clinical trials in my 30 years for sexual health for women, and I've never been a part of the lubricant one. That was pretty. I would like to know who did all those clinical trials. He seemed pretty enthusiastic about them.
He did. He did.
I
He's
think doing the brochures would be a great idea to get that between the SSA and them, and to plant those into the rooms of people who are newly injured. Because, like Connor, I was injured 30 years ago, and I don't know anybody that was getting information like that. But it's very helpful because most of the women on like the chat boards and stuff now that you see, they're still asking these days, like, what do I do and where do I go and who do I talk to? So, I mean, it's even if the information is a little more out there, people still aren't getting like great information as they leave rehab and stuff.
No, you're right. It's these topics that aren't touched on, and then
Mhm.
time matters, which is
It does.
what's scary about it. It's like, so
For the guys, apparently. Yeah, I didn't know it was such a
yeah,
critical time thing for guys.
right. So
I've been on the surgical ICU a lot with my time at the acute care, so I think I'm actually going to bring up his name to the trauma
Yeah,
team tomorrow because I do think that a lot of the spinal cords I've had have been young males, especially, and I feel like so much feels like it's getting taken away in a short period of time, and this would be
yeah,
something that could be like
yeah,
not taken away.
A lot
And
of
yeah,
hope can
yeah,
give people.
right.
yeah, definitely.
And especially like he said, it seems like such a time matter thing. And if you're not getting the information, then how would you ever know until I guess
Definitely.
it's too late
Yeah,
or
I think the
whatever.
earliest intervention you can get with that, people would appreciate that. They might not be as responsive right on, fresh out of it, but it's something that, that pamphlet is something like that they could hold on to and, you know, deal with it in a year or whenever they're ready to. But to have that information right away would
Yeah.
be key.
But pamphlet's a brilliant idea.
Yeah,
Just general information. Then they could always follow up for more. But just even having some of those first key bits of knowledge on the fact that that is affected by spinal cord injury too is, I think, really important.
and any links he gives you, you should put up on the SSA site
Yeah.
too.
Yep, for sure.
Ooh.
Oh, I did have a question for, I guess, whoever, maybe Adrian would know this. I know that like some things we're not supposed to like give patients per like